The information provided on Dr. Tom Roselle Live by Dr. Tom Roselle, D.C., interview guests, show co-hosts, or substitute hosts is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. It is for general information purposes only. Information from this broadcast should not replace the appropriate consultation and examination process by a licensed physician. Always consult your own physician prior to changing any current medical directive or prescription.
Hey everybody, welcome to Ageless Health live stream with yours truly, Dr. Tom, and we got a great program for you again, as we always do, one that I think you're going to find very fascinating, and it's kind of, piggyback onto what we've been doing over the last several weeks. Last week we were talking about these turbo cancers that are showing up from COVID and vaccines and so forth, but so much more. I gave you a statistic. I said that the CDC said that post-COVID, the increased rate of cancers showing up is 14,000% higher. And that's also off the information the VAERS vaccine reporting agency is talking about it. We know that those are minimal compared to what's really happening out there. So that's why we're doing this program on breast imaging and cancers and so forth. Going up on the 11th, which is coming up this week, we're going to be doing an in-house program at the Roselle Center for Healing in Fairfax. Derreth Painter will be my presenter, my co-presenter. I will be there causing all kinds of trouble. But my job is to give you the pieces of physiology related to cancer, the things that potentially could make a difference. Derreth is going to be talking about thermographic imaging and how that is really one of the primary, as far as I'm concerned, diagnostic tools with a lot of different things, but particularly the predisposition to cancers. And you've heard her on the program before, both on the radio program on WMAL 105.9, but you also heard her here on Ageless Health live stream. And guess who's my guest today? Derreth Painter. We're going to talk about the efficacy of breast cancer. Hey, Derreth, thanks for joining me again.
Thanks for having me again.
Well, we're gonna dig into this. This Wednesday night's gonna be a lot of fun. I'm going to I'll be the silent person in the background for a short time.
Be silent.
Well, sometimes I got to behave myself. Not always, but sometimes.
We'll see.
We'll see. Yeah, I know. I'm threatened like I usually am. Always. It's tough to walk into my own office.
Things up.
Yeah, right. Okay, we'll go 3 rounds later. Okay. Hey, listen. So what I want to talk about going into the program is the effectiveness, if you will, of thermography. We've talked about what it is and lead into that just a little bit, but then I really want to talk about how effective is thermography in cancer screening, and a little bit about, and I know this Wednesday evening you're going to show images, you're going to actually show and demonstrate, you're going to talk about a lot of different pieces that we're not going to touch upon today. But let's start with that. Let's talk about, just for a nanosecond, kind of a recap of what we've talked about with it. But let's get into the ability of this thing to really be effective in a screening process relative to breast cancer.
Sure. So before I can talk about the effectiveness, let me just tell you first what the differences are in the different types of screening processes that women and men have options for. Traditionally, women have always done a self-breast exam, where they go into their doctor and they palpate and check while the patient is there. And then you do once you hit the age of 40, recommended by the medical establishment, that you do an annual mammogram. Now, the mammogram is a process in which we basically x-ray the breast tissue at its lowest common denominator, as most women will very intimately be aware of, where they squish down the breast tissue to its lowest common denominator to see whether or not they can find any anatomical anything.
Yeah, they crush it, 45 pounds of weight.
Yes.
Just saying.
We all are very familiar with that. And with women who are either small chested or have implants, sometimes that is significantly more uncomfortable. Although I think most women totally would say it's just not a comfortable process. But the aspect is they're looking for an anatomical anomaly, in which case they will then take the patient into a process of either doing an ultrasound or doing a biopsy, either a needle biopsy or a core biopsy, both of which are not comfortable either. But ultrasound's typically not painful, or so the efficacy of that is dependent on the woman's breast tissue. If you have dense breasts, which a lot of women do have, at best the mammogram will be an inconclusive call because they're unsure whether or not they can see through the density of the tissue. So there's mammogram. In relation to thermography, we're looking at something completely different. What we're looking for is blood flow. We're looking for metabolic changes over time. So what we're looking for are the precursors to that anatomical aspect being visible within the mammogram. So we're looking for something called an angiogenesis. That is a separate vascular system that develops in the breast tissue or develops in the lymphatic system that actually is the feeder to the anatomical aspect we're looking for in the mammogram.
So the science, as you said, is up to about 8 years, even prior to the development of the tumor?
5 to 8 years, we can see the activity, active activity, prior to a tumor or a cyst being developed big enough for mammogram can see. So again, we're looking at two different things. One's looking for anatomical, the other one's looking for metabolic. So that's where you have to differentiate what the two diagnostics are doing. Most of my patients obviously want to get early detection so that they have more choices and they have more time to look at treatment efficacy and whatever they choose to do, they and their doctors choose to do.
You know, it's really important that people understand that once you get to the place of being able to identify a breast lesion of some sort by mammographic imaging, which is radiation. So let's make sure that everybody understands that. It's basically a CAT scan for breast tissue that it's been developing for quite some time. And that at that point, once they see it, not only is it there, but is it really there? Number one, false positives. But if you do the thermographic imaging, if you will, and you have the ability to see vascular something, you have a network, a stream, an increase of heat signaling that wasn't there before. And we understand that it may be there way before the formation of the cancer, whether it's ductal, whether it's invasive tissue, whatever it might be. It doesn't tell you, one, that in fact that's what it is. It doesn't tell you how long necessarily it's been there, but it tells you something's there, correct? Right. And then you have to take the next correlation, the next steps. And the next step isn't necessarily a mammogram. The next step is two other processes. What would that be?
So in the US, the standard of care will tell you that the mammogram, if it comes up with a positive finding, that you go in for an ultrasound and or they go just directly to the biopsy. But typically they do ultrasound, and from the ultrasound they'll do a biopsy, typically a needle biopsy. Now, as you and I have talked in the past, there are some risks to a needle biopsy, something called seeding. Once you put the needle in to get samples of what's inside that aspect, that anatomical aspect, once they draw it out, you run the risk of kind of spreading that. Let's, God forbid, be a pathological or a cancer, then you run the risk of spreading that throughout the breast tissue. If it's a false positive and it's just a adenoma or a fatty tissue, then obviously no harm, no foul. But there's still that risk. So that's the typical progression is mammogram, ultrasound, biopsy.
Interesting in Europe what they do in most cases, where they, after they do the ultrasound, um, and they find something, there's something there. Though, and if in this country they're going to do a biopsy, and again the risk is because of the seeding pattern. I've said that for years and years and years, and but they'll actually go in and they will surgically take out, incise the tumor that's there, so they don't spread it, so they don't seed it, if you will. And that's a far better option if that has to be done, in my opinion, because of what we see, than the others. So let's talk a little bit about the tool itself, the thermographic tool itself. How effective is it relative to imaging of pathology?
So it's only as good as the pathology is active. And what I mean by that is, if we're looking only for pathology and we're not looking for other stages or other things that it could be, what we have to depend on is that active cancer cell duplication. So cancer cells typically in the breast tissue typically duplicate every 30 to 90 days. So we're going to see that activity over time as it starts to get hotter, warmer, and start to diffuse in through the breast area. So that's how we can monitor suspicious activity. We cannot diagnose this is breast cancer. We have to have other things that are going to confirm the pattern of behavior that we're seeing.
So you said something that I want you to repeat again, because I don't think our audience really can appreciate how quickly it advances from nothing to, oh my God, something, right? How fast does it duplicate?
Typically 30 to 90 days. Now that's for an average type of cancer, and I hate to say average type. In younger women, typically from, like, let's say 23 to 35, it can actually progress faster. Whereas women in their 60s to 70s will progress slower. And if you think about it, I had several of my patients who were in their 70s and 80s. My grandmother being one of those people who in their mid 80s was diagnosed with breast cancer. And the protocol was do nothing, because the cancer cells were so slow growing that they would survive, they would outlive the cancer before they would outlive the treatment, such as chemoradiation.
Now, I'm going to just throw a little something out there, because I'm going to cover it with you on the 11th when people come to the office for this program. The hormonal relationships when it comes to breast, prostate cancers, and so forth are very similar, and they have to do with buffering of estrogens, whether environmental estrogens or they're estrogens that are produced in the body. So what do I mean by that? That means that if estrogen levels get too high, there has to be an adequate amounts of the right type of progesterone to buffer it. Otherwise, it becomes cytotoxic. That means it destroys tissue, and that's where your cancers come from. So there's a way of making that happen. The things that they're doing today to supposedly blunt that process. We have a friend who developed prostate cancer. And so the man is in his 70s. And what they did is they shut down his production with Lupron of testosterone and testicular production of testosterone. The next step is they go to the adrenal system. The problem with that is that you need adequate amounts of the right type of testosterone to heal with. So if you shut that down, your healing just went out the door. The reason they shut the testosterone down is because in a normal physiological process, when you have testosterone, that's where the normal estrogens come from the adrenal cortex. So a woman, for example, who no longer is having a menstrual cycle, she produces her estrogens primarily from the outside shell of the adrenal system, but she first has to produce testosterone. No testosterone, no estrogen. And then the other pathway is going into pregnenolone into progesterone. So that whole process is a balancing act. So when you don't take that into consideration, you don't understand what the process is, and you're going the wrong direction, finger pointing, if you will. So let's get back to, again, sidebar, but let's get back to the thermographic image as an effective tool, if you will, to screening of breast cancer. How effective?
I would say it very effective in consideration of what we're trying to look for. We're looking visually as to whether or not we've got an active pattern of pathology or if we have a hormonal imbalance. For example, I will often see when women look at the thermography as I'm doing it, they go, "Oh, there's a lot of red and white. Do I have cancer?" And I'm like, "No, you're fibrocystic. Your estrogen progesterone levels are, all over the place, and you may need to do some balancing, as you say, balancing act with your doctor." So we get to see a lot of what's going on in the tissue aspect as far as potential lymphatic congestion, potential, estrogen imbalance, other infectious aspects. As you and I have talked before, I recently had a young woman who came in absolutely terrified because she had pain in the axillary area of her right side. And as I was screening her, I have a tendency to kind of do a little bit more than just the breast. I noticed that there was a lot of drainage up and around her face area, specifically up in the jaw tooth area on the right side. And I asked her, "Do you have anything going on in teeth and gums?" She said no, not that she was aware of. She did have wisdom teeth removed. She did have some, I think, other work done. And long story short, we found that she had a cavitation in that upper area that was draining into the lymphatic,
Yeah.
that was into that right breast. And there's studies now that show that chronic infections sometimes will lead to other cancers, to include breast cancer, cancer of the intestinal tract, all of those things. So we kind of get a picture of what's going on in the body from an inflammatory standpoint that may kind of give us a roadmap as to what's going on with this particular individual. And that's the nice part about thermography is it's not invasive, and it's not there's no radiation involved, there's no pain involved, and women are not likely to avoid coming in and getting screened, whereas thousands of women will avoid going in and getting a mammogram because of the pain and the cumulative radiation, and I mean the list goes on and on.
Or anybody that's had 6 mammograms increases the risk of breast cancer significantly. It goes up to something in the neighborhood of about, I think it's 40-50%. But it's something to pay attention to. The science behind this stuff, as far as I'm concerned, not thermography, but mammography, is skewed. And as always, I'll tell people, if I remember last week, I told people, I said, anytime you hear something, anytime you read something, anytime that you see something that's skewed one way, ask the question, first of all, who's saying what? What do they have to gain by it? And who's writing the check behind the scenes? If you can answer those questions often, even directly, indirectly, you get a little different look at things. We know that mammography has about a 20% false positive, false negative error rate. And some people say it's even bigger than that. In thermography, if you will, what's as far as, and we're not going about cancer, but identifying something, what's the error rate in its ability, false positive, false negative, in identification?
The actual numbers I'd have to look up as far as updating, but it's the error rate is very small. But as I mentioned before, we're looking for active pathology. So if it's encapsulated, we're not going to see it. If a woman is past the angiogenic stage where the body is no longer regenerating the cancer cells, kind of in a almost a remissive state, we're not going to see that. We have to actually see active activity taking on. So in any diagnostic testing, you're going to have some level of that. But as I've mentioned to a lot of patients before, this is not the end all. I don't want them using just thermography as a screening tool. You've got a lot of other things that you can use. For me personally, mammogram is the last on the list because I've had cancer before and I want to limit my exposure to radiation. So I'd rather do the ultrasound, I'd rather do the blood work, do all of those things. And then if I need to, then I would, if there's a purpose for me to do that look, then I would do that.
I was taken back. I think it was about a week ago with a patient that came into the office, and we're looking through the cancer profile she had because she had had active cancer at one point. Wanted to know if it came back, and they wanted to do these invasive things. And I said, "Why isn't your doctor running markers?" And she says, "What are you talking about?" And I said, "How about CA-125?" She says, "What's that?" It's a primary marker for ovarian metastatic cancer. And her doctor had either no clue, I don't know, didn't run it for whatever reason, but wanted to put her through all this other invasive stuff before, it's like, why are they doing things in other parts of the world and saving lives exponentially compared to what we have here? In my opinion, thermographic imaging is something that should always be considered as part of a routine annual physical examination because it finger points to something that just isn't right. Now you can take the next step. As you said, thermography, then ultrasound, then MRI. Where they want to do radiation, then the other pieces, maybe, or they want to just jump in and do a biopsy, which we talked about being not a good thing to even consider, in my opinion.
Right. So in the U.S., the standard of care is mammogram, and that's why a lot of doctors will, continually I hate to use the word hammer, but I'm going to say that just because um, all the majority of my patients will sit there and go, I'm avoiding going to my doctor because they're going to berate me for not going in and getting my annual mammogram. And I'm like, well, that's kind of your choice is how you want to go through your process. And I've had patients cry and say, I can't do it. It may be the patient you were just talking about. She has told me absolutely, unequivocally, I will never ever do another mammogram again. And I'm like, well, don't rule it completely out, but at the same time, it's that constant bashing of the patient saying you have to do it the way we want you to do it instead of having your doctor collaborate with you as to how best to get the information so you know what steps or what options you have. I mean, I have a great doc where she knew that I didn't want to do the initially, and she said, let's do the ultrasound. Let's see what other options we have once we get those results. I went in to get the ultrasound, and I was not treated in the best way. I didn't tell them I was a thermographer, and I was told I was taken in and out of the room 4 times, told that I had to do my mammogram, and I said, no, not today. I have a script that says ultrasound. After a lot of to do, I did get the ultrasound, but the radiologist refused to sign the report. And when I contacted my doctor and told her, she said, yeah, they already called me and told me that standard of care is mammogram first, then ultrasound, then this. So we didn't have a choice. In Europe, um, there's choices. That is not, mammogram is not their primary. Um, so it's kind of limiting. And then, as you said before, you have to ask yourself, why such a stringent protocol, and why are the doctors in such a tone to demand that the patient do it in this way, one size fits all?
lots under the table, and there's a lot of reasons. Europeans, as far as I'm concerned, have a better sense of propriety and respect for the human body than we do in this country. And it's for a lot of reasons. But even something as not small, that they will not allow food that is not pure organic, non-GMO to be imported into the EU from the United States. It's against the law. And it's because they know that we poison ourselves through what we put into our foods and how we grow them and so forth. So just think about that for a while relative to what's happening and what we're talking about with thermography. This Wednesday evening, the 11th of September already, Derreth will be our presenter. We're going to be talking about the advantages of using this. She's going to show you images so you can actually see what they look like. I'm the guy that's going to be talking about some of the hormone relationships and how they go hand in glove. So we're going to kind of go back and forth on this. So join us. All you have to do to register, we ask you if to do that for us. Go to drtomroselle.com. That's drtomroselle.com. And register there. You can do it the old-fashioned way. You can call the office, 703-698-7117. You go to the Roselle Center website at rosellecare.com. Either way, do one of them. Listen, we'd love to meet you. We'd love to see you. We'll answer all your questions. Whatever it takes to serve you, we're happy to do that this coming week. So we'll see you on the 11th. Thank you for joining us. Derreth, appreciate taking the time to join me again. You are at the top of the feed chain when it comes to this stuff. I am humbled with the background that you have, but want to encourage everybody, join me next week. We'll have another interesting program for you on a different topic. And just know that I continue to do this only for one reason. I love you all. Have a great day. Bye.
you.